very much. Thank you very much, Mr. Chairman and Ranking Member Peters, for having this hearing. And it is good to hear agreement about the importance of population health to our homeland security, because that's one of the reasons that so many of us want to make sure that every American has access to good health care all up and down the spectrum. I also wanted to thank all of the witnesses for your participation today, and just comment on the fact that what I'd like to focus on is not a binary choice between opening our economy and having more people get COVID-19, some of whom will terribly and tragically die from it, or stay in a lockdown forever. I think there is another path, and it is the path that public health experts have been talking to us about, which is how do we implement public health tools, use the right kind of public health tools to reopen safely, protecting life as well as livelihood. So, Dr. Inglesby, I'd like to start with a question to you, please. First of all, thank you for your work during this pandemic to help provide medical and scientific expertise about what we need to be doing to keep Americans safe and our country strong. There's already been some mention in our discussion today and in some of the testimony about the need for more daily testing, but I want to return to that topic because I think it has to be a focal point of any conversation about reopening the economy. As you know, there are a variety of reports from public health experts projecting how many tests per day will be required nationwide as a part of a safe reopening strategy. The Center for Ethics at Harvard recently put out a blue ribbon report stating that as a nation, we may need 5 to 20 million tests per day. Other estimates have been even higher. So, Dr. Inglesby, while I realize that modeling can vary and is dependent on a variety of factors, based on your research, have you determined how many tests we need to perform on a daily basis in order to fully reopen the economy nationwide? And are we at that level currently?
So right now we're testing somewhere in the order of about 250,000 people a day, give or take. And we have been focusing primarily on people who have severe illness, people who are hospitalized, people who are in nursing homes. And then to some extent, the outbreaks that we've talked about, meatpacking, et cetera. We know that we're missing a large number of people with that strategy because we haven't had testing to be able to reach out to them. So people who have mild and moderate illness that could be COVID, we're not easily able to test them. They either can't get a test or they can't get it quickly. And so our estimate at our center is that given the number of people that we believe have been infected in the country that have not been counted, we believe we need to scale up testing by an order of 5 times or so daily. So that would be about 1 million tests a day to get the full complement of everyone who has COVID symptoms on a daily basis in the country. That might go down if the epidemic gets better, but for now, given the numbers that we have, we think that would be the approximate number. What that doesn't, I was just going to say, it doesn't include, the one thing it doesn't include, which the Harvard Center also tried to get to and others, is the second category of organizations that want testing, which is business in America and institutions, universities. They want to include testing as part of their reopening strategy. They want to incorporate screening. They want to incorporate sentinel testing. And so if you include that, that's another additional set of testing, which we have, there's no real estimate yet that's been created by big business in America. But I think that would add millions of tests a day if we actually are able to do that.
And do you have an idea of when we could reasonably expect to get to the point where we are doing the level of daily testing that you're talking about? Let's start with the 1 million that would be testing people with symptoms or on the front lines and the most ill. And what will it take to get there?
I talked to a representative from the diagnostic industry earlier this week, and their sense is that they are getting close to that number in terms of being able to manufacture that number of tests, 1 million tests a day. But clearly that number is not actually happening. And part of the reason for that is maldistribution in the country. Part of that is lack of reagents. They might have a test kit, but they don't have the right reagent. Right. They may not have swabs. So to get the whole, we may have actual kits for that many people presently, but we don't have the full package or the operational planning to be able to deliver those tests to where they need to get.
And what could we do as Congress to help us get there?
I think continued monitoring of industry and a commitment to the industry that this market is secure, that if they make tests for COVID-19, they will be purchased by the US government for this process. And I think that's probably something that they're aware of, but I don't think they have a sense of what market size the US government wants or US industry wants. And so there's some uncertainty. Should they make capital investments? Should they shut down other lines in favor of this one? Are they going to be crowded out by other diagnostic developers? I think it's a complicated calculus for them. And the more that the US Congress and the administration could say, we intend to purchase these, we intend this market to be secure, it will grow over time because we need it for business, university, institutional purposes, as well as public health, I think that could help.
Okay, thank you. I have one other question for you, Doctor, and it follows up really on the line of questioning that Senator Peters had. In recent weeks, even with social distancing measures in place, we've seen outbreaks of the disease at businesses and at gatherings across the country. For example, 81 employees tested positive at a Walmart in Massachusetts last week. It's unknown how long the virus was spreading within that store or how many people those employees had contacts with. In order to reopen in a way that keeps employees, customers, and families safe, we need to be able to contain these types of outbreaks before they become widespread. And that requires support beyond diagnostic testing for people with symptoms. So we talked with Senator Peters some about the things businesses can do to open safely, the kind of guidelines they need. But could you focus a little bit on the importance of robust contact tracing to contain community spread and immunity or vaccine registries that could be used to protect high-risk individuals?
So all countries in the world that have done well against COVID-19 so far have had very strong public health capacity and the ability to do contact tracing and to isolate cases and then quarantine contacts and track them over 2 weeks. We saw that in places around Asia. We've seen it in New Zealand, Iceland, countries in Europe. The places that are succeeding have very strong contact tracing programs. And we are beginning to move in that direction. States have announced programs to hire many contact tracers. Congress has done a number of things moving in that direction. The reason why that's so important is because that's a way to cut off the chains of transmission. That's a way to get people isolated so they're no longer infecting others, and that gets people out of commission for a bit at home, and it begins to drive down the numbers of infections. And we've seen this in great detail in places around the world. So we need to build that. It's not complicated to do it, but it takes some time. It takes resources for states to hire people. It doesn't need to be a commitment for 10 years, but it needs to be a commitment for the course of this pandemic.
Well, thank you. I think it also would be very important in terms of giving the public confidence that when they do go out and they do engage in commerce or any other activity of their daily lives, that the likelihood of them being in a safe place is much greater. And I think that goes to the concerns that the public understandably has about this disease. Thank you, Doctor, for your work and testimony. Thank you, Mr. Chair, for this hearing.
Well, thanks, Senator Hassan. We don't have a Republican teed up. What I'd like to do is I see three witnesses with their hands kind of up. They want to say something. So I'll give them each a shot. I'd appreciate succinctness before we go to Senator Rosen. We'll start with Dr. Atlas, then we'll go to Mr. Roy, and then to Dr. Katz. Dr. Atlas.
Okay. Yeah, great. Thank you for allowing that. Just a couple of points of clarification. And these are things that keep being repeated, but they're just misconceptions. Senator Romney said that the curves are not coming down because the number of cases are actually going up in certain states. That's really not a curve to really watch at this point. We know that the more testing we do, the more cases we have. That's not a relevant curve. That was never a directive goal of the policy. The only curves that count are the number of hospitalizations per day and the number of deaths per day, not the number of cases. Second point that is, again, needs to really be clarified. There's somehow a false narrative that's being perpetrated that the people who don't want total lockdown are saying there should be wide open economic and isolation. That's actually not true. No one here is saying that. I don't know anyone who believes that. Everything is about targeted protecting the at-risk people and allowing people to get out who are not in those groups, particularly so that we can increase herd immunity. And then one more point, if I can, about testing. You know, the role of testing is important, but it's very different at various time points in a pandemic. The role of testing in the beginning for South Korea and the urgent needs were very different than it is right now, especially for contact tracing. We have tens of millions of people who have had the infection here. Contact tracing, it seems sort of absurd to me unless it's for preparation of the next pandemic. And then the final point, we keep discarding the massive harms we're killing people with total isolation and lockdown. I don't know how many times this has to be said, but hundreds of thousands of people have serious diseases that are not being treated. And not just that, the economics alone is causing a massive catastrophe that is in terms of health and poverty throughout the world, because many economies are linked, in fact, the whole world, to those of the United States and the Western world. Thank you.
Thank you, Dr. Atlas. By the way, is it Mr. Roy or Doctor? I don't want to.
Mr. Roy is fine.
Okay.
Is fine. Thank you very much,
Then,
Senator.
How about Ovik? Mr.
Yeah,
Roy,
that
go
works
ahead.
too. Yeah. Similarly, I want to clarify a couple things. First, quickly, with Senator Romney, I think misunderstood my comments of comparing to other types of fatalities. I wasn't comparing to the flu. COVID-19 is clearly more serious than the flu, especially for people over 65 and those with cardiovascular chronic disease. My point was to analogize to traffic fatalities and hospital-acquired infections to say, we don't shut down hospitals because 100,000 people die of hospital-acquired infections. We try to manage and mitigate and reduce those deaths. Similarly, with traffic fatalities, we have a whole regulatory system in place and impress upon people that need to be responsible. Those kinds of tools can be relevant here, just as they were in the East Asian countries that recovered from SARS in 2003. I want to make one other comment about the testing discussion we were just having. It's very important. I think a lot of people are under a false impression about just if we have X number of tests, then everything's going to be fine. We have to remember that antibody-based testing or serology testing does not generally measure an active infection. Antibodies only generate in a patient 3 weeks or 4 weeks after they've been infected. So for testing the population to see if they've been infected or they have a current infection, it's not going to work. And the DNA or viral RNA-based testing, RT-PCR tests, those are much more invasive at the moment, much more cumbersome, and very difficult to scale up. So when we talk about the number of testing, I think it's unrealistic to expect massive population-wide testing. And people who are interested in more details about that, we can either get into it in this hearing or you can review the freeop.org paper I mentioned earlier, where we delve into this topic at length.
Thank you, Mr. Roy. Dr. Katz.
Thank you, Senator. I also wanted to comment on testing, which I've seen up close and personal in the emergency department, and it is cumbersome. And one of the issues we have to overcome is the unreliability of a lot of the tests we're using. There still is a high false negative rate. But it does seem to me we're setting up a catch-22 if any semblance of return to normalcy is predicated on a number of tests we know we can't do and won't be able to do for the foreseeable future. I think we need to ask ourselves, what do we need the data for? We want to know what % of the population is likely to get this infection. Is it everybody who's exposed, or is it 1 in 5? So far, it really looks to be about 1 in 5 on Navy ships, on cruise ships, and contained populations. Of the group that gets this, how many develop symptoms? Of those, how many need to be hospitalized? Of those, how many are likely to need the ICU? Of those, how many are at risk of dying? And on the basis of what antecedent risk factors? How does that shift with the presence or absence of hypertension, coronary disease, type 2 diabetes, body mass index, and other factors? When we think about the utility of data, we really aren't bogged down with testing millions of people. We need a representative random sample large enough to give us that actionable information. That's much more doable. We have the resources to do it now. It's proximal. It's the work of several days. And if the goal of getting data is not just to say, look how much data we have, but look what we now understand to inform policy, representative random sampling will do. The other thing I wanted to say is that there's an alternative to contact tracing. And that is to say, we identify people at higher risk and we carefully protect them from exposure to the virus. And people at low risk, we actually expect the virus to circulate. So contact tracing in that group almost defeats the purpose of saying low risk people, if we're ever going to get our lives back and not be on the indefinite timeline of maybe there will be a highly effective vaccine mass produced, we actually need the virus to circulate among people who can safely get it, get over it, make antibodies, which historically before the advent of highly effective vaccines was how pandemics ended, immunity developed. But what we can do now, artfully, is say there are people who cannot safely get through this infection. We'll protect them. There are people who can, they can go back to the world. I think contact tracing at scale in that group is not likely to be helpful. And I think we should do better than contact tracing for the high risk, people over 70, people over 80, people with a large burden of chronic disease. We need to double down on protecting them so they're not exposed until we can document with ongoing, at least random sampling, that viral transmission is near zero, that a high level of protective immunity has been achieved, and then basically everybody's grandparents can hug their grandchildren safely again.
Okay, well, thank you, Dr. Katz. I feel bad because I lost Senator Rosen. I know Senator Sinema is available. So Senator Sinema, why don't you go? And then I see Dr. Inglesby as well as Dr. Corey have some points to make, but let's go to Senator Sinema first.